about today, my risk and someone who is at the low end of the spectrum, their risk, right, begins to become equal. The take home message from all of these people were that yes, we are born with somewhat of a high risk, but almost all of that risk is surmountable, meaning by effective lifestyle. So, what we repeatedly tell people across the board is please, please, please don't blame genetics for bad outcomes because you, as a human being, has control by creating a lifestyle that is likely to override all of those factors. And among those factors, the critical one that then Renu will get right into is the visceral fat. And I'll let her take it over from here.
So once again, thank you all for joining. We are super excited. And for people, as I said, who have not watched Brown Heart, it is actually my personal story of life. Despite doing a very healthy lifestyle, diet, exercise, maintaining a low BMI of less than 23, and no family history of heart disease, I actually had heart disease and decided to show up in the middle of a hike. So again, I don't want to get into details, but that's really what has been the motivation behind making Brown Heart. Because when we did research or literature review, the studies on heart disease in South Asians have been going on for 60 years or more. But why haven't we conquered heart disease till now? And as a physician, we learned so many new things that we thought if we don't know about it, how is the community supposed to know about it? And that's what the whole motivation was behind the Brown Heart. So one of the things which we don't get into very much detail in the documentary, but we learned from Dr. Yajnik in Pune, who we interview, and he has done research on this for the last more than 70 years. Probably one of the first ones in London and India to start that research. So one of the things South Asians have is we have a lower BMI, which means we are thin. We are called the thin fat Indians. We are thin up till here, but then all our fat is distributed in the belly. And the belly is not just subcutaneous fat, it is the fat in the visceral organs, which means around our liver, around our heart, around our arteries, around our kidney. And that is what really causes the insulin resistance, which means your body doesn't utilize insulin properly. And that is the marker for prediabetes. And that is the marker for inflammation and heart attack. And what, with very elegant study, he actually showed that when he measured the fat in babies, he compared them to babies in London and Pune. And what he found was that the babies who were born had a higher fat when they measured the MRI. So they did MRI, and they found that they had more fat around this area in the babies that were born and a much lower muscle mass in our upper and lower extremity. And as South Asians, you know that we have very little muscle mass. We just don't have good muscle mass like other babies are born. So the visceral fat story actually started with genes with the small babies. And then this continues because our kids do not exercise and have fast food, add diet onto it, and then add multiple other things. And that continues to increase that visceral fat. So visceral fat is probably the most important regulator for heart disease among other risk factors. And what is the simple way of finding out visceral fat beside doing extensive testing is your waist circumference. Because as Indians, our BMI is actually lower, but if you measure waist circumference, and for South Asians, if you're 90 centimeter in men, or if you're above 80 centimeter in women, you have a higher risk for heart disease. And that data has been proven in the research. The second thing, which we get into, we learned that yesterday from another cardiac seminar, that you can actually do a weight-height ratio. And if that ratio is more than 0.5, so it's even simpler than measuring a waist circumference, it's another risk factor for heart disease. So whichever way you want to do it today, measure your waist circumference or look at your weight-height ratio, you can find out your risk of heart disease. So that is about the visceral fat. And again, we'll take as many questions as we can. We'll try to leave enough time for questions. The second part, which I really get into, is the woman in heart disease. And I think there are a lot of women on this forum probably. And as women, we always think, hey, we are protected from heart disease because we have estrogen. And there's no doubt about that estrogen protects you from getting heart disease. But after menopause, the risk of women getting heart disease is exactly the same as men getting heart disease. And the risk rises like this. The second problem, even though we have so much focus on breast cancer and uterine cancer, we only focus on women, and we talk very elegantly. Somebody talked that we are only focused on the bikini area and nothing else. But the death from heart disease is 10 times more common than breast cancer or any other cancer in women. So that's number one thing about women and heart disease. The second most important thing, the women today, young women today, if you develop gestational diabetes, if you develop preeclampsia or hypertension during pregnancy, or if you are obese at a young age, all that estrogen protection goes away completely. And your risk of heart disease rises much sooner than menopause. And the third important thing about women I want to talk about is that risk of gestational diabetes is actually passed among generations. And one of the Usha, I'm forgetting her last name. We interviewed her, and she said this very eloquently that when a woman has gestational diabetes, and if she has a baby who happens to be a female, so that female ovaries are bathing in the glucose of mother. So not only that baby is now has a high risk of diabetes, because that baby is a female, her ovaries and the third generation is also at a risk for getting prediabetes, diabetes, and heart disease. So as a woman with gestational diabetes, not only you're increasing your own risk of heart disease, which goes up by 3 times if you have gestational diabetes, you're increasing the risk of diabetes and heart disease in your young daughter and your younger granddaughter or grandson. So it affects 3 generations. And finally, that is the story of my life, that with menopause, every woman's LDL starts to go up. Whether you do a diet, exercise, or do whatever, the LDL just naturally increases. In some people, it increases by 10 to 20 points. In my case, it increased by 60 points, despite excellent habits. And of course, I did not start statin thinking I'm very healthy. Nothing is going to happen to me. And by the time I started cholesterol medicine or statins, I already had developed heart disease. So I think the take home points is you need to start taking care as a woman, you need to start taking care of yourself today while you're young and not even have become pregnant.
Thank you, Renu. So as you can tell, so we've gone from genes to the importance of visceral fat to the generational kind of a, I wouldn't say transmission because it's not like it's an infectious disease, but the generational kind of impact of women getting gestational diabetes and then moving on to the next generation. So then the logical next step in this process, if you think about it, is so what do we kind of begin to do about this, right? So we are more prone, somewhat genetically. Then we begin to accumulate visceral fat. And particularly in today's environment, if that begins to happen earlier in life, so let's say even in young children and in teens, by the time you're 25, you are already at a pretty significant risk because you have begun and in many instances have a significant amount of visceral fat in you already, right? So what do we do now? So the next step is my job to take you through what we spend a significant amount of time in the film, which is diet and exercise patterns. So let me actually kind of reverse this and start a little bit with exercise, only to make 2 points. One is, while we are on the topic of visceral fat, exercise is a wonderful visceral fat buster, right? So think about it, and I'll say this: some people among us, among South Asians, are more susceptible to the positive effects of exercise on visceral fat than others are. But suffice it to say that there was at least one study from Hong Kong that we actually quote in the film, where what was found was that while for everything else we say, you know what, it's diet, 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 80% diet, 20% exercise, when it comes to accumulating visceral fat, But when it comes to busting visceral fat, right? Not obesity overall, not overall reducing weight, but busting visceral fat, exercise is an amazing way to do it. And both aerobic exercise and developing muscles in some manner by resistance training. So I'll again take you through a couple of stories. So when we were traveling in Scotland, actually, Dr. Raj Bhopal, who has actually published a book and has done extensive research on this, talked to us very eloquently about this. And there was a question on our group chat today about sarcopenia, meaning reduced amount of muscle in South Asians. The reason I bring that up now is what Raj Bhopal talks about is that not only do Indians have more fat, but like Renu said earlier, they also have lower muscle mass, right? And these two things are connected. So one thing is we need to lower our fat, visceral fat. The second thing is we need to increase our muscle size. So Dr. Raj Gopal was very interesting when he said, you know what, when I hug, a Caucasian friend, they seem more solid. But when I hug an Indian friend, Renu, do you remember that? And he said, when I hug an Indian friend, they seem like kind of flabby, right? So I thought that was very telling because what he was saying was that Indians not only have more fat, but have less muscle. So they feel kind of less solid in that sense, right? So now if you think about that, from an exercise perspective, we talk about the fact that not only should you get into a regular sequence of aerobic exercise, but that very early on, you should start some form of resistance training and weight training, right? Because it does both things. And both of them will cause you to lower visceral fat and therefore increase or lower your chances of heart disease. Now, one thing while on the exercise topic, and then I'll give that up and I'll get to the diet part, is that when we then talk about exercise, it's fascinating. So when I see patients, Indian patients, invariably when I ask them, do you do exercise? They'll typically say, I do yoga, right? And I commend them for it. I almost always say, wonderful, please keep doing that because yoga has data after data after data, meta-analyses, what have you, on heart attack prevention in general, right? However, yoga, except a couple of very unique specific types of yoga, is not the same as aerobic exercise and not the same as resistance training, the two modalities that I just mentioned to you, right? So yoga is not a substitute to a cardiac friendly exercise program, but has independent benefits. So please keep doing it. So on that note, I call this all eggs in the yoga basket. That's what we as Indians do, right? So you will see these days people getting big time into yoga, but they are still not exercising. The Masala study has found in the United States, as many of you know, that Indians in the United States have some of the lowest exercise rates among all ethnic groups. And it's exactly the same thing back home in India, right? So that needs to change. And if there is one thing you can start with, please, please, please start with some kind of an exercise regimen. Now on to diet. So if you really look across if you just fall back and think about cardiac risk prevention or cardiac risk and what we can do about it, I feel that the Indian diet is probably the biggest culprit when it comes to putting us at high risk. And the corollary is also the biggest opportunity to lower our risk, right? So we talk in the film about our diet being kind of a multi-pronged risk to our cardiac health. So what we do is we typically have a fairly large amount of carbohydrates, right? Growing up, I was raised in the hills. I'm from Nainital originally. I was raised in the hills, and my diet used to be a big heap of rice in the middle of the plate, and that would cause Anita to have a heart attack if she thought about the plate method on that one. The whole plate would be rice and a boatload of dal on top. Thank God for the dal. Otherwise, the rice itself would be killing me by the time I was 20. But the point being, high carbohydrate. Polished rice is one of the most inflammatory foods, right? So that's one. A large amount of, even if we're vegetarian, we think if we're vegetarian, we are kind of healthier. But the fact of the matter is, even if we're vegetarian, a large amount of our food can be deep fried with a lot of fat, including saturated fats and trans fats. And then the third big problem is that our diet doesn't have enough protein, right? So now remember the connection between protein, muscle development, lowering visceral fat, increasing muscle mass. So low protein is a double whammy in that sense. High carb is a double whammy. It gets you the calories, it gets you the bad kind of calories, and is highly inflammatory, as it is called, meaning it encourages inflammation in the blood vessel wall of the heart, of the cardiac vessels. So all of this to say, when we do all of this, our inherent cultural diet pattern is like this. As we go on in life, very early on in life, we begin to accumulate visceral fat and all the things that come with it, right? So, by the same token, we then need to do the exact opposite with our diet. We have to unlearn the dietary principles that we learned as children. So, what we've been repetitively saying to people is that you need to lower your weight overall because many people have a high BMI, high meaning above 23 in South Asians. When that happens, they can be maybe a little bit higher than 23, but nevertheless higher than 23. So if they do that, they have to get their weight down, but most importantly, to be able to get the visceral fat down, you have to unlearn all these three things: increase protein in diet, lower the fat in diet, and lower the amount of what are called simple carbohydrates, which quickly get absorbed into your bloodstream. So as you can see, this is where all the connections are up until now. So we've discussed the 5 buckets, and I'll now let Renu get into the meditation pieces. But for right now, as I close this topic, I'll say all of these, as you can see, are so closely connected to each other, if you can tell. So I'm going to pause there and let Renu get into the next bucket before we move on.
So before we go there, I think the exercise, somebody has also asked that question, so it is better to answer here. The when Nirmal was saying about aerobic exercise, the American Heart Association recommends that we do 30 minutes of 5 days a week, which is 150 minutes a week of aerobic exercise. What that means is you need to have your maximum predicted heart rate. So that is calculated by 220 minus your age. And if you take 80% of that, that's where your heart rate should go. So if I'm 60, 220 minus 60 is 160, and 80% of that is close to 130. So when I'm doing the exercise, my heart rate should go up to 120 to 130, and that will help lose the visceral fat, improve overall fat, and improve cardiac disease. And along with that, you need strength training at least twice a week for 30 minutes. And that you can do with bottles, with weights, with dumbbells, with a personal trainer, whatever you want to do for your strength training. So you can build both upper and lower extremity. Not only it helps build muscle mass, but it also helps prevent falls and other conditions. So that's what the exercise I just wanted to add because that was a question right there.
So
Now
just to Renu, correct for 1 second, 80% of maximum predicted will actually get you into zone 3 or 4.
yeah,
But
80,
zone 2,
60 to 80%.
actually 60 to, I just want to make sure we have the correct number. So zone 2, which is the minimum required for aerobic benefit, is 60 to 65-ish% of maximum predicted heart rate. So go ahead, Renu, please.
Yeah. Okay. So now let's get into the other bucket. And again, as I said, we'll take as many questions as we can. The meditation, as he has very rightly said, the most underrated weapon. And we find that by talking to many celebrities, by meditation experts, when we interviewed them, and there's data after data. And I do know that the South Asian Heart Center incorporates all of that in their personal training and coaching when they do this. But meditation clearly has data that if you do 15 minutes of meditation, because stress has been really associated with heart attack. And what we found, there was a very elegant study done by Dr. Mohit Gupta in Delhi, where he looked at people between 22 and 35 years of age who had heart attacks with no other risk factor, but they only just had stress. And what he had found was that their telomere length, which is one of the chromosomal length which decreases with age, their telomere length was already low, equivalent to a 65 years of age. So even though they were 30 years old, their age it was equivalent, their genetic age was equivalent to 65, which led to cardiac disease and heart attack at a much early age. So how do we decrease stress? And meditation is one of the best way to decrease stress. I mean, I'm not going to say that you stop working in life. I retired as vice president. He retired as CMO. So we both had very stressful jobs. And I do think that that may be one of the reasons why I did get early cardiac disease. The stress may have played a role in my life as well. And I was not a proponent of meditation at that time, but 15 minutes of meditation. And I think the TM or transcendental meditation has the best data where you're either reciting a mantra or doing many other things. But there are two or three different type of meditations you can do. You can do breathing, you can do body scan, you can recite a mantra. You can do whatever you can do to calm your mind. And I think if you do 15 minutes in the morning, 15 to 20 minutes in the evening, that calms your mind down, stopping your cell phone, preparing for sleep. And I think meditation and sleep goes hand in hand. So if you're less stressed, you're going to sleep better. And that has really been proven to be a very, very significant factor in cardiac rehab. And these people who had heart attacks, the cardiac rehab patients, when they did meditation, they prolong their life and prevent a second cardiac disease from happening. So now what I'm going to do is, and again, as I said, there's so much on each topic to talk about. And then I'm going to get a little bit into the nostalgia roots, and then Nirmal is going to talk more about natural and meditation hesitancy. So as a diabetologist, I am frequently asked about, oh, I don't want to take medication. Can you talk about ancient? I'm taking Karela, I'm taking cinnamon, I'm taking this jadi booty, and I'm taking this herb, and I will control my diabetes. So I'm not against any of that. Any of that. I think our Ayurveda is filled with a very nice collection of herbs, and literature talks about it. I think most of their role is in prevention, but not in disease. So if you have pre-diabetes, and if you're dying diet and exercise and healthy lifestyle, and maybe your sugar is still a little high, if you want to take Karela, if you want to take cinnamon, if you want to take other herbs, I have no problem you taking them, realizing that the multiple studies, number one, the studies are very small. So even though we have practiced Ayurveda from ancient times, from 500 years, and they have a lot of good values, I have nothing against that. The research of published literature is on small amount of patients. So like Karela has 3 or 4 different study on 100 to 200 patients each. And on an average, the glucose drop was only 10 to 13 points. So if you think your sugar is very high and Karela alone is going to do it, I doubt it. You will have to do diet, exercise, lifestyle change, and everything together. So by all means, you can use natural things. There's nothing against it, but be cautious that if you're doing other medications, there may be interactions. So you have to make sure that you talk to your doctor about it, you tell them what you're taking, so there's no interference with the other medications. Nirmal, do you agree with that? And do you want to take away?
Yeah, absolutely. And I think this is a good time. I'm looking at the time. I think I can take a couple of the questions along the way so we can keep doing that because some of them are difficult to comment on the chat box. So I'll take the one on exercise real quick. The comment, all this stuff is good traditional knowledge. The aerobic range is an elevated heart rate, but not too much. It should be sustainable for 10 to 20 minutes or more. Absolutely correct. Time didn't allow us to get more into that. The only point was that sometimes our Indian, friends or patients will say, I exercise, but when you ask them, they never get to zone two. So that was the logic of spending the amount of time on zone two. But your point, I think you can look at the chat box, but the other point is what about high intensity interval training, HIIT? Both Renu and I are avid proponents of high intensity interval training. It's a wonderful thing in a short period of time, bursts of exercise. Both of us do it regularly. bursts of exercise followed by, so 1 to 3 minutes of exercise followed by 1 to 3 minutes of a lower intensity exercise or none. And there are various combinations of that. They are both paths to the same destination, right? There is a lot written about high intensity interval training, and it works wonders, by the way, particularly for visceral fat. It works wonders. And for busy people who can get it done in 20 minutes, it works great. However, there is a concept of what's called area under the curve, meaning there is also a lot of literature on doing aerobic exercise. The longer you stay in zone two, the longer the benefit. So you get a big area under the curve. HIIT allows that area under the curve sometimes to be established pretty quickly. But there is also volumes of data on the other. So it's not that one is in fashion and one is not. Both are good, and both are, paths to a common destination. I have many people who struggle with high intensity interval training either because of bad knees or another problem or a physical limitation. So I give them either option. Neither is good or bad.
I can take there's a diet question quickly, I think, before we move to the next one. So the question came in that we need to eat reasonable amount of protein, not too much starch. What about fats? Traditionally, practitioners say that fat is all bad, but the modern idea is that some fats are healthier than the others. So it is true that natural fats, milk fat, healthy fats from olive oil, nuts and seeds are good, whereas processed oil, deep fried fast food is not good. So I think you're already giving the answer. Yeah, everyone needs carbohydrate, protein, and fat. So we think 50% of the diet comes from carbohydrate, 30% from protein, 20 to 30% from protein, and 20 to 30% from fat. And you can change that based on what your individual diseases are. So fat is equally important to sustain life, to change into carbohydrates when needed. And you're absolutely right that you need good kind of fat and there's bad kind of fat. So what Nirmal talked a little bit about was the saturated fat, and saturated fat is bad for your heart. The unsaturated fat is good for your heart. Trans fat, which is usually in Indian sweets at a very high level, like trans fat is banned in all countries, and jalebi itself has 17% trans fat. So we need to cut out the trans fat through the fried foods because that's the biggest source of trans fat. Any oil that is room temperature solid, that is just a general principle. If it's solid on room temperature, which has the biggest thing is coconut oil, and ghee actually is in that category. So not all desi ghee is not completely bad. So if you want to take a teaspoon or a tablespoon, that is actually, we can only have 7% of our fat from saturated fat. So if you take 1 teaspoon to 1.5 teaspoon of ghee every day, your saturated fat is already over. So you cannot have saturated fat from anything else. So answer is good. Yes, you need the seeds, you need the olive oil. All of that is very good sources of good fat. And again, you can watch the documentary and watch our podcast on Indian diet, and you'll get a lot more data from that.
So we'll keep moving ahead for right now. Looking at the clock, we have 15 more minutes to go. So I will do the last couple of buckets real quick while we continue to answer your questions, and we'll take as many as we possibly can. So this next bucket that I want to spend just a couple of minutes on is what I would call, one thing I said about this exercise thing and yoga thing. Renu got into the Ayurveda thing and what we struggle with. The data, hard data on treatment modalities with Ayurvedic remedies is extraordinarily limited. And one of my goals is to begin putting out evidence-based information on some of these things, whether it be Karela for diabetes and so on. And much more of that is going to come up in our upcoming podcasts and our short reels. So stay tuned for that. But along the same lines, I want to spend a couple of minutes on this, what I call a South Asian obsession with natural. That just because it's natural is good, and just because it is not natural or synthetic, that it's bad. Now, this is rooted in very solid, reasonable information, meaning natural, when you compare it to processed, right? There is a lot written about why processed foods in a variety of ways are a problem, right? And in that sense, natural versus processed, natural will always win, right? But now, when you begin to compare natural with things like modern medications, completely different ball game. Meaning, A, I'm not saying one is good or bad. The point is, it's a continuum, it's a spectrum. So think about it. There are things that are natural that are wonderful, but there are things that are natural, whether it be a datura plant or another toxic plant that is horrendously bad. Secondly, there are things that are natural, used for depression, St. John's wort, some other things, where you have no idea, because it's not regulated by the FDA today, as to how much that natural remedy actually contains. And clinical studies on natural
Julio,
remedies are
Julio,
played.
okay.
Whoever is,
थोड़ी देर में था डिबेट
can you
था
please
डिबेट
mute
Can you mute?
yourselves? Can you please mute yourselves? Thank you. And then when you look at these natural remedies, there is no good way to control the amount. On the other hand, modern medications, good, bad, or indifferent. Again, I'm not here to say, there are side effects, there are issues that can happen. But all of this is in front of your eyes. You know it. You know these are the side effects. They're being published. There are published trials. 15% of people will get muscle aches. 36% of people will develop another side effect. So what you see is what you get. So this obsession with natural, personally, I think is one of the biggest issues that I deal with when it comes to medication hesitancy. We talk a lot about this in our film. I have patient after patient after patient who has delayed appropriate preventive tactics, who've delayed appropriate treatment just because they don't want to go on medications. And we say this all the time, and Renu very eloquently talks about it in the film, where what we talk about is, if you delay effective therapy that is well established modern therapy for something, today you might be avoiding one medication, but if you develop a heart attack, God forbid, you're going on 5 medications easy: aspirin, beta blockers, ACE inhibitors, a whole bunch of other stuff, not to mention lifestyle that is impacted. So please, please, please evaluate things with your head, not just with your heart. I think that's the important take home message. It's a big problem in our Indian communities, medication hesitancy. And then the last bucket, and then we'll get into a little bit of the questions. Is that the flood of information on WhatsApp and other forums, that everyone and their brother is a doctor with very few credentials, and yet everyone has an opinion. Now, as an informed consumer, we love the fact that you are educating yourselves on your own and pushing people like us to say, hey, what do you think about X? Why are you not doing this test for me? We love that when that happens, because you are an informed consumer. However, when you then begin to extrapolate those views, and people do that all the time on the internet, you as an informed consumer is charged with the responsibility to then separate substance from a whole lot of noise. And we have entire videos on how to spot misinformation from information. That's for another day, but for today, suffice it to say that please, please, please carefully look at the source of information before you make a judgment on its efficacy or its side effects. Okay, so that's, I think, an important piece. And the last piece, Renu will talk for a minute or so on Know Your Body. I think this is we have an entire podcast, so maybe we can refer people to the podcast, Renu, but your call.
Yeah, I think just a quick thing in 2-3 minutes. I just want to know the simple things you can do today to know your body. If you do not know what's going on, you're not going to save yourself from heart disease. And very simple things: BMI, waist circumference, know your sugar, get your fasting sugar checked, whether you're pre-diabetic or diabetic. And because South Asian Heart Center does all this, I'm not going to get into details. Know your lipid numbers. If you, as a South Asian, you haven't done your LP little a or apolipoprotein B, every person as a South Asian above age 25-30 should at least get an LP little a or apolipoprotein B, and sooner if you have a family history of heart disease. And we get into documentary a lot more that most of the South Asians, especially with family history or other risk factors, should get a CAC score done very early in their lives, between 35 to 40 years of age. Because if you have this, so the CAC score is a very different modality of test, which is not covered by insurance even now, but it costs $90. So it's a pretty cheap test otherwise, where you have a 2-minute CAT scan and it tells you the calcium in your arteries. And if your CAC score is anything above zero, and there's Dr. Alka Kanaya has now published normograms as to what your CAC score should be at different age. And if your calcium score is high and you even have a lipid level of above 100, you should start taking a statin. So again, as I said, time will not permit us to get into that. The more you know your body, the better you are. And Dr. Priyanka Satish, who is a preventive cardiologist, part of the documentary, has done a full lecture on this, and we'll put that podcast here as well. So you can listen to that. It talks about all the preventive testing you should be doing to prevent cardiac disease today. And I think there were a lot of questions on diet. And I would strongly encourage you to listen to the podcast on diet, which we did several weeks ago. And we do these podcasts once a month on our Brown Heart WhatsApp group. So you're welcome to join that. And these are recorded so you can listen to them at their own time.
So I've posted the WhatsApp group joining site. If anyone's interested, you can join in. There are no forwards, no greetings. 90% are posts from Renu and I. Occasionally, people will ask actually quite frequently, people will ask specific questions that allows us to design our podcasts and so on. So I've put this summary up or this link up there for you. I'll just crank through some of the questions real quick. The first one is, we always get a
Dr.
whole...
Joshi?
Yes.
Yeah.
Yeah. From our side, we generally say 1 hour, and whatever little extra time you have, you are free to answer the questions as
Okay.
much time
All
as you have. I know it's late night.
Yeah, no worries at all.
Okay, so
Yeah,
there is no
as
hard
long...
stop at 6:30.
Oh,
That's
okay,
all I
great. Thank you,
wanted to
Anita. I appreciate that. So in that case, I think, so let me just quickly take a couple, and then Renu can take a couple after that, and so just because there are a bunch on statins, I'll make a couple of comments, I think, for the good of everyone. So perhaps the most questions we get are two: what cooking oil should I use? And are statins bad for you? Right? The cooking oils thing, I'm going to turf off just because there is an excellent podcast that we've spent the time on, including some excellent tables and so on and so forth on there. But the statin question real quick. Can statins cause prediabetes? Yes. High dose statins will cause, a certain proportion will cause prediabetes. When you overall on the aggregate today, in today's date, when you look at in the right circumstances, decrements in LDL cholesterol is perhaps the most highly effective cardiac prevention tool, other than preventive tools such as lowering your weight and exercise and all of that, right? But decrements in LDL cholesterol is a critical piece of lowering your risk. And the most effective way to do that remains statins. However, anything in life comes with a risk and a benefit, right? That's the massive benefit. It comes with a little bit of a risk. So if that's the benefit, that's the risk. Small incidence of, nuisance muscle aches. I've been on all 6 statins known to man and eventually went to Repatha, which is a PCSK9 inhibitor. One of you made a mention of that. Superbly effective medication, not paid by insurance until you fail all statins or you get side effects from statins. But the risks are relatively small. What we know today, in all humility, this can change over time, but what we know today is that statins have a tremendously positive impact on the LDL, which in turn is an extraordinarily effective heart attack lowering strategy. So that's one. On the question of, I think one of you earlier had asked...
Rosuvastatin daily weaken muscles, and it's recommended to take CoQ10 to reduce muscle contraction issues due to statin use.
Yeah, so let me just quickly comment on that. So rosuvastatin, the benefit of rosuvastatin compared to other statins is that for a smaller dose, it is perhaps one of the most potent statins today. By the way, we have no conflicts of interest with any drug makers, just so you know. the lowest dose of rosuvastatin will get you more mileage than perhaps other statins, right? Now, statins do not cause muscle damage. They cause muscle enzyme elevation that is transient, that when you stop, or reversible, I should say, when you stop, it'll go away. Thirdly, that it will, but the side effects, I've dealt with all of them. The side effects are sometimes there are nuisance side effects. And when that happens, you should look for other potential possibilities. But back to rosuvastatin, the CoQ10 in some patients will lower the symptoms associated with muscle aches and so on. Renu and I have found, and we've talked about this offline more than once, that it's a quick test. In some people, when CoQ10 works, it works wonders. If it doesn't work within 3, 4, 5, 6 weeks, you just need to stop it and move on. If you're a candidate where it's going to work, it's going to work. There is another strategy that works for statin-induced induced muscle aches, which is in people, and for me, that was extraordinarily beneficial. A lot of us as Indians have low vitamin D levels, right? So if you're having side effects of statins, have your vitamin D checked. And if it is low, which many of us do, you need to get it above 40. And sometimes, in my case, for a good 2, 3 years, I was able to be free of statin side effects while I was on vitamin D supplementation. What else?
I'll take one. What is the advisable aerobic exercise after having angioplasty? And obviously, the aerobic exercise can be done after angioplasty, but you will probably have to first see your cardiologist to make sure that you are given a clean bill of health from them. There may be a period of time they may not want you to go into aggressive exercise, but once that period is over, and that has to come from your cardiologist after stenting, when you can do it. But once your stent is completely done and you're back to your normal echocardiogram function, your EF is good, and he's allowing you to do it, then you can go back to your regular aerobic exercise routine, which you're doing to prevent another stenting. So I think, and one first question, which I would not ask by Narendra, but I cannot comment, Nirmal, I don't know if you know about epigenetics and gene expression. I am not an expert on that, so I don't want to say anything wrong. We did interview the people who were working on the genetics, but we didn't get into those details. So
I would love to. The only problem is I would have to kind of build a little bit of a background, and we may not have time for it. But what I will do is I will post the answer for you later on, definitely in our WhatsApp groups. Happy to send it to you offline. But it's a great question. It's a very, very exciting field, by the way. So it's a wonderful question. I don't want to gloss over it, which is why I won't. I think there was a question, Renu, you might want to take this. And then someone answered it very nicely too. If a person is mildly diabetic and overweight, what is the better approach? To take metformin or GLP-1 drugs like Ozempic? Among the various GLP-1 drugs, are they all similar to Ozempic, or are some different and hence better or worse than others? So this is Renu's sweet spot, since she's a diabetologist.
I'm a diabetologist. So for the pre-diabetics and early diabetics, we always start with metformin. And the reason behind that is metformin is cheap. It's a $4 drug. It has been time tested for 30 to 40 years, and it really does not cause kidney disease as people think. And you can have long-term data on metformin for 10, 20, 30 years, to the point that it's now even recommended, even if you have advanced kidney disease and your GFR is above 30, you can still take metformin. So metformin is the starting point, but GLP-1 have really changed the course of both diabetes and heart disease. So not only GLP-1 improve diabetes very quickly, they improve the weight by 10 to 50 pounds. So much more weight loss with the GLP-1 than metformin, which really improves sugars and maybe a very little weight loss, 5 to 10 pounds, but not much. So why are GLP-1 so different? So there are 2 or 3 theories, but biggest thing is they decrease insulin resistance, they decrease your food, they slow your gastric emptying, so you're really not able to eat as much, and they're really the hormones which are produced in your own body. So GLP-1 have been great. The other thing which has been good with GLP-1 is the cardiac data is phenomenal. GLP-1 have now at least 10 to 12 papers that they prevent the development of cardiac disease, because by lowering the obesity, by improving inflammation, by going into so much, I can't go into every detail of how GLP-1 works. And having said that, not all GLP-1s are great. Ozempic is currently approved for diabetes, and a counterpart of Ozempic is also approved for obesity alone. The newest drug, Mounjaro, which is the latest in the pipeline, and there are few more coming. Mounjaro has even higher weight loss than Ozempic, so even to the point of 40 to 50 pounds. And Mounjaro also has very strong cardiac data. Several of them have now been approved for sleep apnea. So if you have sleep apnea, you can take one of these drugs. And again, with obesity, loss of weight, the sleep apnea gets better. I think the biggest problem is two things. Number one, if you're titrating GLP-1 very quickly, you will lose the muscle mass as well, because you lose fat mass, but you also lose muscle mass. So titrate it slowly so your body only loses fat, and you keep on doing strengthening exercises to build up your muscle. The second important, if you do not do diet and exercise and you do not modify your lifestyle, as soon as you stop that GLP-1, your weight is going to come right back. So you have to be very cautious about that. And of course, the number three, they're so expensive that it's just hard to afford them. There is some small case reports coming on different side effects, but the side effects are much lower as compared to the benefit they produce.
Yeah, so I'll plow through a couple others real quick. Is CoQ10 vegetarian? Yes, there are vegan options out there depending on the brand. You can get vegan options in CoQ10. What is your opinion, recommendations on high triglycerides? High triglycerides are how should I say, an accompanying risk factor for cardiac disease, typically not alone, but in combination with other risk factors. But very importantly, moderately high triglycerides, meaning triglycerides between 250 to about 750, moderately high triglycerides are an indication, an early indication of metabolic syndrome, which is a risk factor for heart disease. So and currently, particular types of omega-3 fatty acids, one particular type, which has been, we recently put it out on our WhatsApp groups, is there is excellent evidence to indicate if there is moderate elevation in triglycerides and you are a pre-diabetic or diabetic, lowering that triglyceride with Veskappa, which is the medication that I'm talking about with the specific type of omega-3 that has been proven in relatively well done studies to lower the risk of heart disease. So I
And I
think
will take one on the lipoprotein A because
yeah,
that's very
please.
important. So
Sure.
Lp(a) is a genetic marker of cholesterol, which is 25% of South Asians have that. So each one of us should get an Lp(a) testing just one time in life, because there are no drugs right now that reduce the Lp(a). So you need to know if your Lp(a) value, and the normal value is up to 75 in some labs, up to 50 in some labs. If it's usually above 50 or 75, you are at a very high risk for, again, developing heart disease in combination with an LDL. So if your Lp(a) is positive and you have an LDL which is borderline like 100, 110, 120, there are at least a few papers out there which talk about keeping your LDL less than 70 at every cost if you have a high Lp(a), if you want to prevent heart disease. So that's how you lower your risk with Lp(a). And I think this, if you can take this, an important one and taboo topic in our community, mental health and cardiac disease.
Yeah, I mean, I think that it's a complex topic, but I'll make a couple of comments related to that. Mental health is a conglomerate of different disorders. I think the connections with cardiac disease are inherently three types if you want to think about it. One bucket is what I would call the connection with depressive disease, both as a cause, after an MI, depression, and so on, number one. Secondly, depression itself as being a risk factor. Second bucket is stress, which is super well published and at this point, thankfully, extraordinarily well known, the association of stress and heart disease. The third bucket is least known. So while there is taboo related to perhaps the first bucket, which is depression, and the third bucket, which is disorders such as schizophrenia and hardcore mental illness, the connection of that bucket with underlying cardiac disease is least well studied. but the connections between depression and anxiety and stress is extremely well studied. And I think part of what the South Asian Heart Center does extraordinarily well in working with people, particularly with stress and the meditation processes that they work with and coach, I think are tremendously useful and part of their meds protocol. So medication, exercise, diet, and sleep, which are critical elements of that. The one other question along the way was around I think there is and this again has been repetitively put in our WhatsApp groups, and I'll make a brief mention of it as to what does so this word calcium has then been kind of added on to, hey, if you took a lot of calcium, can your CAC score be impacted by that? And it doesn't quite work that way. However, large amounts of calcium supplementation is not recommended, and there is some question other than some very specific indications of calcium supplementation. In fact, someone asked me yesterday if the calcium salt of atorvastatin was bad for them. That's how atorvastatin is given. There's nothing wrong with that at all. So don't get into that trap of, is calcium going to go straight into my arteries? It's not a clear linear equation like that at all. And then someone had also asked, is there a reason why physicians currently don't order CAC scores or coronary artery calcium scores and lipoprotein little a more frequently? This is something we get asked all the time. If the data is so good, why doesn't my physician know about it? Well, the short answer is many primary care physicians, no judgment here, simply are not as well versed with the data on South Asians, which is why you need to become your best advocate with the best available scientific information to advocate for yourself and push your primary care doctors to order. And if not, Anita and Ashish always remind me that the South Asian Heart Center can do all of that for you if you are part of the part of the program, which is such a wonderful program. We are huge fans of it. So keep that in mind. But the fact of the matter is, those two tests are vital. In my opinion, every adult South Asian should know their CAC score and their LP little a. I believe ApoB and a couple other things, which are part of the South Asian screening protocols that they've nicely put together, and we can put that out again on our chat line, on our WhatsApp group lines.
And South Asian Heart Center is very well represented in our documentary, and we learn so much from them every day. So I think they've been a great team to be associated with.
Yeah. So let me see. I think the film we already talked about, www.thebrownheart.com. That's where you can access the full film. It's an entirely nonprofit charitable venture. It was funded by philanthropy. The sole intent is to get out to people. And then oils, we have a nice little, we won't answer the oils questions here. There are one of the most frequently asked questions. If you go to www.thebrownheart.com, there is a section on top that is frequently asked questions, FAQs. All of the questions up until a week ago that have been asked on the WhatsApp group and answered by us with supporting evidence is part of that. So some of these oil questions, some of the CAC score questions, there are about a repository now of about 70 questions as part of that, and we update them every week. So you can access many of the questions there. I think this is a good time. I know we are, where are we right now?
We are close to 6.
Yeah, I think just one thing, I think they're asking, will taking estrogen in women help cardiac health? No, estrogen is not used for cardiac health because estrogen is now only used for menopause prevention with symptoms. The long-term cardiac data is not supportive, and there's an increased risk of uterine cancer and breast cancer after 10 years of estrogen use. So we typically do not use estrogen for cardiac health. So I think if you can put the WhatsApp group again, or you can send it to your people, Anita, I think that'll be great.
Well, I think that we have a boatload of people who have joined. I'm putting it here again just to be sure. And then Yep. Once again, I think thank you so much for this opportunity to be able to be in front of you. Like I said, every opportunity Renu and I get to be able to spread the message of cardiac prevention in our South Asian, colleagues, we always take the opportunity. And please, please, please watch the film. Take the time to watch the film. Be an active participant in coaching programs such as the South Asian Heart Center. What a wonderful way to be spreading the message of prevention, and people who have been doing it for over 16, 17, 18 years on a voluntary basis. What a wonderful thing, Anita, you and your colleagues have done. So we thank you again for being such an important part of this journey. And Renu and I are deeply grateful for you to offer us this opportunity. Thank you very much. If you have any comments, we'll wait until you do that.
Yeah, and thank you. I would like to officially thank both Dr. Renu and Nirmal Joshi. Ever since I have met them 2 years back, almost 2 years back, it has been a real pleasant experience, and we continue to learn more and more from you as you man your WhatsApp group, as well as any interaction we have. Even in today's talk, I learned a few new things too. So thank you for doing this. It was very well attended, and thank you everybody for joining us.
Thank you so much. We appreciate it. And you folks have a wonderful night and stay well and stay blessed. Bye.
Thank you so much for inviting us.
Thank you. Bye.